Hi, this is Dr. Shafiq Cheema. I'm professor of nephrology at Allama Iqbal Medical College. Today we will be talking about lupus nephritis. It's a nephritis secondary to SLE or systemic lupus erythematosus. This lecture would be basically targeting renal or nephrology fellows, but medical officers, house officers, and medical students and practicing physician could also benefit from it. So let's start with the pre-test. A 32-year-old woman with a history of SLE associated with rash and polyarthritis is referred to you for evaluation of proteinuria and microscopic hematuria discovered by routine urine analysis. Which of the following is correct regarding the diagnosis workup of lupus nephritis? Proliferative lupus nephritis does not occur with urine protein excretion of less than 1000 milligram per day. It's a wrong option. It could occur because even as little as 500-600 milligram per day, you could have proliferative lupus. That's why we do kidney biopsy. An absence of dysmorphic red blood cells or acanthocytes on urine microscopy rules out lupus nephritis. It does not rules out lupus nephritis. You could still have microscopic hematuria, but you might not find acanthocytes or dysmorphic RBCs, or you could just have proteinuria because you could have membranous lupus nephritis without any red blood cells. So it's a wrong option. Spot urine protein creatinine ratio are less reliable for accurate assessment of proteinuria in patients with lupus nephritis. That's probably correct option. It is not as good or gold standard as 24-hour urinary protein excretion, especially in the cases of lupus. It has been recommended that at least for the initial evaluation, you should use 24-hour urinary collection. But then in terms of following up in an individual patient, you could use the ratio. 4 is urinary concentration. Specific gravity does not influence. It does influence. If you have higher concentration and higher specific gravity, it will show you falsely elevated protein on the dipstick. So it does influence. This is just to check and start up the lecture. So these are the acanthocytes, dysmorphic RBCs, and this is RBC cast, which you must have whenever you have nephritis, because that means you have proteinuria along with hematuria, which is of glomerular origin. So if I have to define nephritis, I would say it's a glomerular hematuria with proteinuria of variable degree. It could be nephrotic or mostly subnephrotic range. And this is a secondary form of nephritis, like diabetic nephropathy secondary to diabetes. This is lupus nephritis, nephritis secondary to SLE. So if you have glomerular hematuria with some proteinuria, that is nephritis. But if you add hypertension, oliguria, azotemia, and it's a full syndrome, then it's nephritic syndrome. But if a patient with nephritic syndrome have rapidly rising creatinine, that would be RPGN, the histological pattern of which is crescentic glomerulonephritis. So whenever we are planning to diagnose a case of nephritis or lupus nephritis, urine dipstick to begin with showing hematuria and proteinuria, then microscopy looking for RBC cast or dysmorphic RBCs, and then protein quantification either with 24-hour urine or urine spot protein creatinine ratio would help you quantify the protein so that you could identify what class of lupus this patient could have. So this is one of my real patient, a 22-year-old patient, medical student with SLE who have who had 2+ protein, no RBCs, no WBCs, creatinine is 1.1, weight is 50 kg. She was diagnosed with SLE in 2020 in Saudi Arabia when she had toe discoloration, joint stiffness, positive ANA, low complement, anti-dsDNA positive, and positive Coombs test. So she did have SLE and now she presented with some proteinuria. How would you proceed? Obviously, you will do the routine workup. You will quantify the protein by doing spot protein creatinine ratio or 24-hour urine. In this case, 40/28 is around 1.5. So patient has 1.5 gram per day of proteinuria. Whenever you have proteinuria of more than 500 milligram, you consider doing a biopsy. So based on the SLIC criteria, you need to have 4 out of 11 to diagnose someone with SLE, but one of them should be from clinical and one of them should be from immunological criteria. So this is the newer way to diagnose SLE as opposed to old ACR criteria. So in the clinical criteria, you have cutaneous lupus, chronic cutaneous lupus, alopecia, oral or nasal ulcer, synovitis, serositis, renal disease in the form of proteinuria or hematuria, neurological disorder, hemolytic anemia, leukopenia or lymphopenia, and thrombocytopenia. So you have to have at least one of these. From these, you need to have at least one of these. Positive ANA, anti-dsDNA, positive anti-Smith, positive anti-phospholipid antibody, low complement, and direct Coombs test. This patient met many of the criteria. So she did have SLE, and we wanted to do kidney biopsy to see what class of lupus she has, because that not only tell you the class of lupus, but that also identify if a patient has more acute changes or more chronic changes. Sometimes the clinical picture could be misleading and biopsies showing something different. It is recommended, these are the indications of renal biopsy in patient with SLE. If you have proteinuria greater than 500 milligram per day or an active urinary sediment with hematuria, we usually consider biopsy. Sometime if you have suspicion of another disease, then you also consider biopsy. Certain times we also do repeat kidney biopsy after initial diagnosis. Whenever there is a newly active urinary sediment after a period of disease quiescence, rapidly rising serum creatinine, new or worsening nephrotic syndrome, or whenever you plan to withdraw the therapy, sometime when you're withdrawing the therapy, you need to know what is the activity index. If activity index is less than 2, then you could safely withdraw the therapy. Otherwise, it's continued for 24 to 36 months. So these are the indications of kidney biopsy: proteinuria, nephritic urine sediment, and decreased kidney function, meaning azotemia, rise in creatinine. So you perform a kidney biopsy and you could find either non-proliferative lupus, proliferative lupus, non-proliferative lupus with nephrotic range proteinuria, and some other disorders like lupus photocytopathy, TMAs. We will discuss all this when we will discuss the treatment. So whenever we're doing a kidney biopsy, there are certain terminology which is used. Focal mean more than 50% of glomeruli, less than 50% of glomeruli are involved. Diffuse mean more than 50%. Global mean in each glomerulus, the whole glomerulus is involved, segmental part of glomerulus. And then interstitial fibrosis and tubular atrophy indicating chronicity. And then activity and chronicity index. And then lupus is divided into 6 classes. So our patient end up having some proliferation in less than 50% of the glomeruli. So she had class 3 lupus. Usually in lupus, you have full house immunofluorescence. It's positive against IgG, IgA, C1q, C3, kappa, lambda, consistent with SLE. So the same patient, after few months of treatment with the MMF and prednisone, was doing fine and suddenly had rise in creatinine, rise in blood pressure. So the question is, what does she have now? What should we be doing? Give the patient, given the patient has proved unresponsive to MMF, we should switch to intravenous IV cyclophosphamide? No. Check antiphospholipid antibody titer? Yes, because the picture is consistent with TMA. So you should make sure patient does not have thrombotic microangiopathy. Increase prednisone to 60? Not really. You need to find out. It would basically, the diagnosis would remain unclear if you just increase the immunosuppressant. And start rituximab, same as prednisone. We need to diagnose first because the treatment of TMA is usually different. So the differential diagnosis was maybe there is another class of lupus, no RPGN, superimposed GN, antiphospholipid antibody like TMA. So the correct answer was TMA. So Because in TMA, in thrombotic microangiopathy, because of MAHA, microangiopathic hemolytic anemia, there is thrombosis in the small arterioles and capillaries, like you see. And these are schistocytes or helmet cells. These are microspherocytes. These are regular red blood cell. Only one thrombocyte indicating thrombocytopenia. And in lupus, it's very significant. This is one of the acquired causes of TMA. And having TMA in patient with positive anti-ANA or anti-dsDNA, most of the time they have underlying APLA syndrome, for which you need one vascular thrombus, which in this case could be thrombotic microangiopathy in the kidney, and one of the test positive, like either lupus anticoagulant or anticardiolipin antibody or anti-beta 2 glycoprotein. So if you have TMA and one of these positive, that's your diagnostic criteria for thrombotic microangiopathy. So in terms of lupus, it's an autoimmune multisystemic inflammatory disorder. Uh, it is a prototypical immune complex glomerulonephritis, and it affects 50 to 60% of patients with SLE. Peak incidence is between 15 to 45 years. Female are more affected, 15 into 1 as compared to male. 10% of patients with lupus develop end stage. However, this depends on histological class. Risk of ESRD over 15 years is 44% in class 4 lupus. It's more common in third decade of women of childbearing age. They're at a high risk of SLE. There are certain genetic factors which predispose you to lupus, and then there are certain environmental factors which could also affect. The pathogenesis is there is a derangement of T and B cell immune system. There is more production of autoantibodies like ANA, anti-dsDNA, anti-Smith. These antibodies bind with antigens, forming antigen-antibody complex, activating classical complement system, and generation of a membrane attack complex, as well as leukocyte infiltration and release of proteolytic enzymes, causing glomerulonephritis, as well as damage to the kidney, leading to the clinical picture of lupus nephritis. The clinical manifestation, in addition to extra renal manifestation, which we discussed in the SLIC classification, in terms of kidney, this is a better cartoon. You could have proteinuria in almost 100%, but only 65% have nephrotic syndrome. Hematuria around 80%, red blood cell cast in only 10%, cellular cast, reduced kidney function, RPGN in 10 to 20%, hypertension in almost 50%, and hyperkalemia in some. So whenever you're planning to diagnose a lupus, in addition to urine analysis, urine microscopy, spot urine protein creatinine ratio, you will send all the autoimmune workup. And based on the SLIC criteria, you will diagnose SLE, and then you will need a kidney biopsy to classify which class of lupus nephritis patient had. So in terms of classification, it has been divided into 5 different classes. The first one is minimal mesangial lupus nephritis, in which there is only uh, deposition in the mesangium and there is no proliferation. Clinically, it manifests maybe with the minimal proteinuria. The second one is mesangial proliferative lupus nephritis, where you could have some hematuria and proteinuria, and only in the mesangium, in between the arteriole, in the mesangial area, you would have proliferation. Then you have class 3 lupus. Class 3 lupus, when the less than 50% of glomeruli are involved, immunofluorescence reveals almost uniform involvement. EM shows immune deposit in the subendothelial and maybe in some mesangium, and it's further classified into class 3 with active lupus, active and chronic lupus nephritis. Class 4 is when the involvement of glomeruli is more than 50%. It's more severe form. You would have more proteinuria, more hematuria, and maybe worsening of kidney function. The deposition of immunoglobulin could be all over the kidney, in the subendothelial region, and as well as in the mesangium. There would be hypocomplementemia, elevated anti-dsDNA, hematuria and proteinuria are present in virtually all the patients in class 4 lupus, and this is the most severe form of lupus nephritis, which could lead to end-stage kidney disease in almost 44% of the cases. Light microscopy showing some wire looping, some increased proliferation, immunofluorescence. Class 5 lupus is a membranous lupus. So this is the most common cause of secondary cause of membranous lupus. You will have subepithelial immune deposits on immunofluorescence. Microscopic hematuria and hypertension could be present, but less common, mostly presents with nephrotic syndrome. Anti-PLA2 receptor antibody would be negative, which is usually positive in primary, as well as IgG4 is more common in primary. If you are checking the split immunoglobulin staining, full housing would be more common in membranous secondary to SLE. These are the deposits. This is basement membrane, subepithelial deposits. Here you could see some proliferation. Class 6 is advanced sclerosing, where you have more than 90% global sclerosis of the glomeruli. This is difficult to treat because there is a significant global sclerosis. Full house pattern you usually see in SLE, where there is a staining against most of the immunoglobulins and complements. And sometimes you could see these reticular, these fingerprinting, or it's also called tubulo-reticular inclusions. This is more common in secondary form of membranous as opposed to primary membranous on electron microscopy. There are certain drug causing lupus, including minocycline, hydralazine, isoniazid, procainamide. Renal involvement is less common in the drug-induced lupus. Class 2, just a cartoon of different stages, where mostly mesangial proliferation, focal proliferation, diffuse proliferation, wire looping. This is a crescent in RPGN. It's a crescentic GN. Subendothelial deposit, subepithelial deposit in the case of membranous and tubulo-reticular inclusion in membranous nephropathy. On biopsy, it's further divided into acute activity and chronicity index based on score of 24 and based on score of 12 chronicity index. And these are the parameters which are used. So the bottom line is if someone has more activity, that means they have more severe disease and it could be treated, versus more chronicity it would be more resistant to the treatment and most of the damage is chronic. These are all the trials of lupus, NIH trials, then ELMS trial, Eurolupus, ELMS maintenance trial, and LUNAR, and different trial using multi-targeted therapy, and the new BLISS, in which they use belimumab, which has shown some benefit. So as a nephrology fellow appearing in the exam, you must know about all of these trials. Because of the shortage of time, I'm not going to go over the individual trial, but I'll discuss briefly when we will be discussing the treatment. Class 1 and 2 lupus, no specific therapy, just supportive therapy, including HCQ and prednisone if needed for extrarenal manifestation. Class 3 and 4, with and without class 5 are treated the same way. The treatment includes the induction phase followed by a maintenance phase. This is exactly showing how we treat it. So if you have class 3 or 4 with or without class 5, so you could give them steroids, intravenous methylprednisolone for 1 to 3 days, followed by oral prednisone 1 milligram per kg ideal body weight, maximum 80 milligram, plus any one of these 4. Either intravenous cyclophosphamide, this is based on the NIH trials, 1 gram monthly for 6 months, or oral MMF 2 to 3 gram for 6 months. This is based on the ALMS trial, or low dose IV cyclophosphamide based on the Euro-Lupus trial, or oral cyclophosphamide. So steroid plus any of these four are comparable. You give it for 6 months, 3 to 6 months, followed by a maintenance therapy in which you maintain the therapy with the low dose of MMF or azathioprine for almost a period of 24 to 36 months. Um, Treatment of resistant or severe lupus nephritis. If this therapy does not work, you wait 3 to 6 months, and then you have all other options. You could consider rituximab. You could add cyclosporin into MMF and prednisone, and you have all these other options. Class 4, 5 lupus membranous depends if patient has nephrotic range proteinuria or subnephrotic range. If patient has subnephrotic range proteinuria, you maximize the supportive therapy, HCQ and renin-angiotensin inhibitor. If there is a response, well and good. If patients still continue to have proteinuria more than 1 gram, then you treat them exactly like you treat class 4, 3 and 4 with lupus as we discussed previously. But if patient has nephrotic syndrome, nephrotic proteinuria, uh, then in addition to the supportive therapy, you start them on MMF or azathioprine with steroid as a first therapy. If there is no response, then you treat them similar to class 3 and 4. Partial response, it depends. And then you maintain the therapy with the same MMF or azathioprine with or without low dose of steroids. These are all the trials we discussed. Um this is the definition we use to see the response. Complete response mean reduction in proteinuria of less than 0.5 gram. Um and partial response mean at least 50% reduction, and also less than 3 grams. So 50% reduction, and the proteinuria after reduction has to be less than 3 gram. That is partial response. So when someone is not responding, you make sure that they are taking the treatment. You make sure you're giving the adequate dosages of immunosuppressant therapy. You could consider biopsy to see if there might be more chronic changes. You might consider switching to alternative regimen. Uh, Consider following inpatient refractory to first-line treatment. Uh, you could combine MMF with CNI in the multi-targeted therapy. You could give rituximab, and you could extend course of IV pulse cyclophosphamide, and now you could use belimumab. Treatment of relapse. If patient responded to a certain treatment regimen, you would use the same one for the treatment of relapse. Pregnancy and SLE. Active SLE at the time of conception is a strong predictor of adverse maternal and obstetric outcome. During pregnancy, if you have to treat lupus, you could use hydroxychloroquine, you could use steroid, you could use azathioprine and calcineurin inhibitor, but MMF would be contraindicated. Um, End-stage renal disease and renal transplant, 10 to 30% patient develop ESRD. They could undergo kidney transplantation, but you have to wait 3 to 6 months before the disease is inactive. You need to make sure patient does not have antiphospholipid antibodies prior to renal transplant. The recurrence rate is kind of low, 2 to 11%. So last, I will end with the post-test. A 35-year-old man with recently diagnosed SLE present with urine protein of 4 gram. On biopsy, found to have class 4 with 5 lupus. Which of the following should be included as part of your discussion with the patient regarding treatment for his lupus nephritis? So he has typical SLE, class 4 lupus in terms of treatment. MMF is superior to cyclophosphamide for treatment of lupus nephritis. No, trial have not shown. In fact, the ELMS showed MMF is not inferior, but it did not show it's superior. So it's a wrong option. Immunosuppressive treatment is typically required for at least 24 months. Yes, minimum 24 months to 36 months. And then sometime it has to be continued for a longer period of time. and you withdraw the treatment very carefully. Some people even do biopsy to make sure there is no activity. Hydroxychloroquine use is not indicated. It is indicated in lupus nephritis because it has shown to decrease the outcome and relapses. Large randomized control have demonstrated that rituximab when added to standard of care as compared to standard of care alone for inducing remission in lupus nephritis. Um, no, there are no large randomized control trials showing this. So this was a brief discussion on SLE and lupus nephritis. I hope you liked it. Because of the shortage of time, I have to run a little bit fast. But if you post any question in the comment, I could answer that in detail. I hope you like it. Please send it to the other doctors and fellows. And I will end the presentation right now. Thank you.